Welcome everyone to the 2021 Just Economy sessions, and welcome to this particular event, bringing it all together, a convening on health and community development investments. I'm Karen Colley, I'm a senior program manager here at NCRC, and my co-host today for this convening is Renee Bedruzman from Build Healthy Places Network.
Hello everyone, good morning, good afternoon. My name is Renee Bedruzman, Program Manager at Build Healthy Places Network. Thank you to NCRC and Karen Colley for organizing this important conversation on health and community development investments. I'm excited and privileged to be speaking alongside Eileen and Kevin today. And we understand and know that from both the community development and the healthcare sectors, that zip code is more important than genetic code. So more than anything else, where you live, particularly where you're born and where you grew up, predicts your long-term health. And people get sick because of where they live. And that equitable distribution of those social determinants of health resources creates the community conditions for people to be healthy and well and thrive. So for example, if people where they live in the community, they have fresh, healthy food available, affordable quality housing, good schools, clean water, air, accessible transportation, open spaces, parks, good paying jobs, all of that determines a person's health and a community's health. And those resources are distributed at a policies and systems level. So I'm really excited again for the conversation today, and thank you so much for joining us.
Thanks, Renee. Yeah, so today's event is part presentation, part discussion on the impact that we can create when we align community investments and foster collaborations with hospitals and health systems and others to reduce health and economic disparities. We know that a good community development can be foundational to building wealth for many, as well as fostering healthy communities and reducing health disparities. So today we'll first have a presentation from Eileen DeVringy. She's a community development research specialist from the Federal Reserve Board of Philadelphia, around opportunities that exist for collaboration between community development and hospitals and health systems. We'll then hear from Renee from Build Healthy Places Network on a scan of policies that enhance collaboration from across sectors and increase healthcare's interest in community development investments in social determinants of health. And then lastly, we'll hear from Kevin Mahaney, Director of the Community Health Investment at Providence St. Mary Medical Center, where he'll provide his practical insights on improving community health from a local hospital system perspective. After our speakers, we'll then move to a more interactive discussion and breakout rooms to dig a bit deeper on the topic and gain your perspective on the challenges and opportunities that propel significant community investment and make health equity happen.
And our staff at Build Healthy Places Network and NCRC will help lead the breakout discussions, which will include both a discussion and participation on a digital whiteboard. We hope the breakout component to the session provides an opportunity to take a moment to pause and consider the ways in which we can leverage cross-sector partnerships and financial investments that improve the social determinants of health, advance health equity, and racial equity. Our speakers will be in the breakout groups as well. And with that, let's get started with our first presentation from Eileen.
Thanks. Hello, thanks for having me as part of this really important conversation today. As Karen mentioned, I'm Eileen DeVringy. I'm a community development research specialist from the Federal Reserve Bank of Philadelphia. The research I'm going to share with you today looks at how much nonprofit hospitals report spending on community development related activities and pulls out some specific examples of the kinds of activities of that sort that they're engaged in. We were hearing a lot from stakeholders in our district. They were really interested in partnering with the healthcare sector on their programs, but they didn't really have a good sense of how to start those conversations or what to expect. So our hope is that by providing some sort of kind of baseline information about their activities, that this would help sort of move those conversations forward. And I'll say when we started this, the COVID-19 pandemic was not on anyone's radar, but it really has elevated and sort of highlighted the urgency of addressing critical social determinants like housing and financial stability, both for the public at large and I think for a lot of healthcare sector organizations as well. So before I get started, I have to provide this brief disclaimer. So the views expressed in this presentation are mine and those of my co-author, and do not necessarily represent the views of the Federal Reserve Bank of Philadelphia or the Federal Reserve System. So I'll start with a really brief background on hospital community benefit requirements and related reporting, both because it's really important context for understanding our results, but also understanding sort of how the IRS defines hospitals' responsibility with respect to these kinds of activities. So to maintain their tax exempt status, the IRS requires that nonprofit hospitals show that they're providing some sort of kind of public service beyond just providing medical services and charging sort of the standard rates for those services. And for a long time, this was a really nebulous requirement, but in 2009, the IRS sort of implemented more comprehensive reporting requirements and required hospitals to start filling out Form Schedule H, where they had to sort of detail their spending in different categories. And there's two categories of spending that we're sort of particularly interested in for our purposes today. The first is spending that's reported on Part 1 of Schedule H, which is referred to as community benefit spending. It encompasses a lot of what you think of would be kind of typical hospital services. And I'll get into a little bit more detail on that in a moment. All nonprofit hospitals are required to complete Part 1. And then the primary focus of the presentation and our research is actually expenditures reported on Part 2, which is referred to as community building activities. These are activities that are more focused on addressing sort of non-medical determinants of health. And again, I'll get into more specifics in a moment. Unlike Part 1, Part 2 reporting is not required from hospitals. So there's a little bit of an imbalance in sort of how the two are viewed in terms of how hospitals are sort of assessed in meeting their public service mission. There's actually no minimum amount that hospitals are required to spend in either of these categories, and it varies very dramatically across different hospitals. So let's take a quick look at some examples or at the subcategories under these two categories and sort of what types of things the hospitals would report on Schedule H. So on the Part 1 community benefit side, you can see that most of these categories are sort of related to patient care activities. There's also research and health professions education, which you might associate with, a hospital that's affiliated with a medical school. But the two that are most kind of interesting for our purposes today are community health improvement services and cash and in-kind contributions to community organizations. Those have sort of the highest potential overlap with community development work, but at the same time, my understanding is that the bulk of those are still going to more sort of medically oriented services. So things like vaccination campaigns, pass-through funding to community health centers, which are critically important, but not necessarily in the scope of what we're focused on. On the Part 2 community building side, you can see there's a lot more categories that much more directly align with community development work. So there's things that are focused on non-medical activities, some of them are place-based, some of them are focused on building capacity and supporting sort of advocacy. So as I've sort of alluded to, the data in this analysis primarily comes from hospitals' 990 tax filings, which were scraped and cleaned and made easy to use on this website called Community Benefits Insight, which is very helpful. We use their API to pull the community benefits and community building expenditures data for all nonprofit hospitals in the US from 2012 to 2016, tax years 2012 to 2016, which was the most recent available at the time. And then we also compiled the narrative descriptions of hospitals, community development related activities so that we could look at kind of specific examples of what hospitals were doing. We did that for facilities that are in the Philadelphia Feds region. So I'll start with a quick look at our findings with respect to that Part 1 community benefit spending, which again isn't necessarily the focus of our research, but is sort of an important piece of context. So in aggregate, hospitals spend an average of about $67.9 billion annually during this period on community benefits, which is quite a significant amount of money. But as you can see from the chart, the vast majority of that spending goes towards sort of these patient care activities. So providing care to people who don't have insurance, or providing care that's not reimbursed sort of at cost by Medicaid, as well as providing health services that are have to be subsidized in order to be available in a certain community. By contrast, a little under 7% of the spending went towards the more kind of community-oriented categories of community health improvement and cash and in-kind contributions. It comes out to about $4.7 billion a year, so still a pretty substantial amount of money. So shifting focus to kind of the main focus of this research, we're looking at sort of the community building expenditures reported on part 2 that are kind of more closely aligned with our community development activities. One thing that's important to note up front is that so all hospitals, since they're required to fill out part 1, virtually all hospitals report some part 1 community benefit spending. On the community building side, a little under 60% of hospitals report community building spending, which is notable in the sense that hospitals aren't necessarily required to engage in this kind of activity, but many of them are sort of opting to anyways. And what we find is that on average, hospitals spend about $474 million per year on these activities. So that's millions with an M. It's a substantial amount of money, but not quite in the same ballpark as kind of community benefits overall. And then among hospitals that engaged in this spending per facility, they spend on average about $270,000 a year. We find that rural hospitals are a little bit less likely to report community building spending, which makes sense because many of them are smaller, kind of less well-resourced hospitals. And interestingly, we find that hospitals in higher poverty counties are less likely to report community building spending. Though when you look at the spending per facility and aggregate spending, it's actually highest for hospitals that are in that second highest poverty quintile. And then by contrast, when you look at the highest poverty counties, the aggregate spending is lowest. And in large part, this is because many of those counties just don't have hospitals, or they have much smaller hospitals. So here's a breakout of spending by category. You can see that these different activities, these different subcategories are funded more or less frequently and at different levels. And one thing that jumps out is that about 2/3 of aggregate spending is in the categories of community support, workforce development, and community health improvement advocacy. And by contrast, a little under 1/5 goes to more place-based categories like economic development, housing, and environmental improvements. So we're also able to break out the spending geographically, and what we find is that there is a lot of variation in spending per capita by state. It ranges from about 3 cents per capita in Rhode Island to over $8 per capita in Delaware. The geographic pattern here isn't super clean, but you can see that the Southeast generally has lower per capita spending, and New England generally has higher per capita spending. And of course, this is sort of a function of where there are hospitals, and particularly where there are larger hospitals. So to give you a sense of kind of more specific examples of the types of community building activities that we found in our research, I pulled together just a few examples in different categories of initiatives or programs that hospitals describe being involved with from the narrative descriptions in their 990s. Again, these are from the Philadelphia Feds region, but it does include, I think, a good cross-section of urban, suburban, and rural communities. And as you can see, this sort of runs the gamut of different activities from affordable housing to human services to youth employment. And all of these things are sort of well within the community development wheelhouse. And there's a lot more examples that are discussed in the report, so I encourage you to check that out. And then to recap our main findings, during our study period, we found that hospitals spent about $474 million annually on community benefits activities, which are sort of the most directly related to community development. The spending was mostly in the categories of workforce development, community support, and community health improvement advocacy. We saw a lot of variation across states, and we found that hospitals in the highest poverty counties and in rural areas were the least likely to report community building spending, sort of consistent with what we would think of as the financial constraints for a lot of hospitals in those areas. And then lastly, just to sort of close out and highlight and move to kind of the next step in this conversation, as the healthcare sector continues to sort of recover from the financial disruption with the pandemic, it's clear that that partnerships and collaboration and leveraging of resources are going to be really important moving forward. And with that, I will pass things back to Renee.
Great, thank you so much, Eileen. I'm going to go ahead and share my screen now. Can you all see my screen?
Yes.
Great, thank you. All right, I am thrilled to introduce the Healthy Neighborhood Investments Policy Scan and Strategy Map. This project was done in partnership by Build Healthy Places Network and with Shift Health Accelerator and supported by Blue Shield of California Foundation. And the two goals I want to highlight today for this project were to identify policies that create a more conducive environment for collaboration across sectors and to incentivize healthcare to consider community development organizations as important partners in shaping policy investments in the social determinants of health. And as we can hear from Eileen's previous research and conversation, that's certainly an area where we want to continue to grow in partnership with. So the Healthy Neighborhood Investments Project, the process included a review of hundreds of policies from across the country. And we were advised by a 38-member policy council in that process. And Kevin Mahaney with us today was a part of the policy council as well. And what came out of that process was an identification of policy actions at the federal, state, and local levels for advancing health equity and racial equity through cross-sector investments. And this creation of a resource or a tool for community-owned priority setting that reduces inequities and revitalizes neighborhoods. A little bit about Build Healthy Places Network. We are a national organization with the mission to transform the way that organizations work across health, community development, and finance sectors to reduce poverty, advance racial equity, and improve health in neighborhoods across the US. The Healthy Neighborhood Investments Policy Scan and Strategy Map is really an acknowledgement that collaborations of community leaders, health and community development, and local government are trying to clear the same policy hurdles and in pursuit of aligned goals. And this slide here really is who the policy scan is for. Those policy hurdles have stood in the way of better health for all, and communities have known this, right? Especially our Black, Indigenous, and people of color, and other marginalized and disinvested low-income communities. And now with today's current climate, it is imperative that all of us advance anti-racism within our laws and policies to create those community level conditions for everyone to thrive without exceptions. So I'll give an example of a collective effort uplifted in the policy scan. The 6 cities and the county of Solano in California created a community action partnership, joint powers authority to provide community services to residents to reduce poverty and homelessness with a focus on safety net services. And this was recognized as a valuable partner for improving health by a local nonprofit health plan called Partnership Health Plan of California, who awarded the Community Action Partnership funding to develop housing projects. So that's an example of the multi-sector partnerships for policy actions uplifted in the policy scan. So on this next slide, you'll see the Thriving Together Springboard Framework, which was a fundamental framework for the policy scan. This was created by the Wellbeing Trust and CDC Foundation. And as I mentioned before, the policy scan really serves as a broad compendium of federal, state, and local policies and the tools for multiple sectors to take action. So what we did in this scan is we essentially organized over 50 policy strategies or so and actions by these vital conditions you see here, that being belonging in civic muscle, thriving in natural world, basic needs for health and safety, humane housing, meaningful work and wealth, lifelong learning, and reliable transportation. So we essentially operationalize this springboard framework specific to policy change, which really connects the framework to real people in real places. And the Policy Council helped us uplift some cross-cutting themes across those vital conditions. And I want to underscore that these were themes as opposed to a top policy list, not because we weren't asked for the top policy list, but because we as the organizers heard from the Policy Council that we should not be determining the priorities of local communities. There's no one size fits all scenario to address health. And neighborhoods at the local level are incredibly diverse culturally and have rich histories. So for those communities that have historically been marginalized or persistently marginalized across the United States, there's often a tale of oppression and trauma existing in those communities, as well as a tale of power and resistance. And those narratives, those stories are only the stories that folks who've been a part of the community can tell, and also a part of the solutions. So if you're listening, whether you're a healthcare administrator, a banker, a community member, or a local public official, these themes apply to help move the needle on racial and health equity across those vital conditions. So for example, we have learned that without civic muscle, without belonging, and without community capacity or community power to make informed decisions, we won't be able to have trusting meetings. We won't be able to have meaningful conversations or honest dialogue needed for policy change, right? And policy is one lever to create change to promote social justice. And the way in which we engage with others to do that policy change can itself be a transformative process. It can be a healing process. If done with intentionality, the policy process can help build trust through commitment to relationships and transparency. It can be restorative, it can promote social connectedness, it can promote inclusion, and it can promote belonging. And my presentation today will introduce the policy scan and strategy map as a tool to create policy action for good. So on this next slide, you'll see a policy treasure map for racial and health equity. And really, this is a visual guide that describes the journey that multi-sector coalitions can take to dig together to find policy solutions for their community needs in this policy scan. And I'm really excited to talk to all of you in the breakout session. So I encourage you all to read the policy scan. Thank you so much for listening. I'm looking forward to speaking with you soon. And with that, I will toss it to my to Kevin Mahaney.
Renee, thank you. And Eileen, thank you for your presentation as well. My name's Kevin Mahaney. I'm Director of Community Health Investment here at Providence Health in San Bernardino County in Southern California. And it's a pleasure for me to share with you the work that we are doing out in the community. St. Mary Medical Center, where I've worked for the past 20 years, is a nonprofit community hospital. We've prided ourselves on not just providing health to people who need it, communities who need it, but also to build community capacity and address quality of life issues. I'm really glad Eileen was able to first examine and share how hospitals have traditionally been investing. And Eileen is right. Her data is showing that there is a large investment in wanting to make health systems better, especially out in the community. One of the interesting things we face in rural communities is the lack of physicians that can adequately serve the community. And so attention that hospital systems will feel is a need to work on both the recruitment and the innovation that allows communities, including communities of color, to more readily access healthcare. One of the interesting learnings coming out of the COVID pandemic has been the use of telehealth, and particularly connecting communities that were needing, because of social isolation, access to mental health. We're going to continue to see hospitals look at community benefit and look at ways to innovate how healthcare can be provided in communities through technology, artificial intelligence, and I should and do want to add, through policy change. I'm pleased to let you know that in San Bernardino County, our public health department has declared racism as a public health issue. Likewise, 2 neighborhoods in our service area, Victorville and Apple Valley, have done the same. This has opened up conversations that we've not had before about how do we examine what has been a status quo misinvestment or underinvestment in communities where innovation and, as Renee points out, policy change can help make communities more equitable. Eileen reported how hospitals could do more in community building activities. And so I want to report out that Providence definitely is investing in the community building activities. We've had a long history doing it. And if I could, I want to touch a little bit on some of the policy opportunities that Renee mentions. Eileen mentioned earlier, and I believe Karen did as well, that geography, where we live, our zip code, impacts health. It most definitely does. There are neighborhoods in our service area where living there would mean you would pass away 8 to 10 years earlier than other neighborhoods. And so this is causing us, both locally and at the county public health department, to question, how are we investing? And then how are other parties investing? And when I say other parties, I mean workforce development, education, the ability to create economic development to bring jobs. The role of hospitals, oftentimes, as Eileen pointed out with advocacy, is to use our brand to bring different parties together to examine these issues, these inequities, and where, as Renee has pointed out, to try to create policy opportunities. I'm going to jump to one. We are working right now in our housing plan, and we'd like to see at least 2 policy changes by local governments that would expand the affordability of housing, that would make affordable housing more common. We've had a problem up here, as much of California has, with just not being able to build enough affordable housing. We see a real opportunity with policy change. And locally, we have at least one city that's very receptive to that, so fingers crossed. With our public health department, we continue to work with them on the idea of implementing policy that would make things more equitable, that would make investments more equitable. I'll be honest with you, it's going to take a little bit of time. The public health departments being very familiar with local communities is sometimes, in such a very large community of ours, difficult. I also want to share that research has been done, and the way Eileen and Renee pointed out, that a county is not going to be able to do this themselves, that we are going to need to build public-private relationships such that we can pull in both state and federal resources to address the inequities that we've had perpetuated in our communities. Let me give you an example. Housing. We've had a status quo where, in at least our community, single-family homes have been the predominant way that we've added housing. Local governments play a large part controlling that. Action at the state level is attempting to be a game changer, to change the way in which zoning is done, the way in which housing is built. We hope allowing multifamily housing to be built on properties currently zoned as single family only. Please understand there's a tension there. Local governments that have had their local communities define how they want to create their quality of life are going to be possibly giving up control. And as control goes to maybe a state mandate, a policy change, there can be a fear of giving up power to a state government in order to try to create more housing. And so local communities are very concerned. They point fingers perhaps at a state and say, with housing, we need to do something. And then when the state wants to do something, there's, wait a minute, you're taking something away from me. I guess I'm bringing up a tension that is very real. Hospitals have to look at how do we make investments that both improve the quality of care that people are getting, particularly communities where they're rural. By zip code, we know they're passing away earlier, that there is disparities by color, let me say maternal, African American mental health issues, long-term underinvestments in those health systems, coupled with the reality that the social determinants of health, such as access to housing, jobs, higher education, and food, play an incredible role, not just on how healthy we are, but on the opportunities that families have in raising their children, such that their children will have a quality of life equal to theirs, or maybe even better, or being able to afford the American dream. Eileen, Renee, Karen, it's an honor for me to share with you the work that we've been doing here in Providence St. Mary, and our embracement of policy and public-private partnerships in an effort to address what has been longstanding underinvestments and the reality that we have been a rural area that is economically developing into a suburban area, but bringing with us urban-like problems of homelessness, the lack of available affordable housing, the ability to innovate to try to create jobs that pay people more such that they can afford the higher cost of housing. It's an honor for me to share with you our work out here, and I appreciate doing so.
Thank you, Kevin. Thank you, Eileen and Renee as well. Hi, everyone. I'm assuming that everyone can hear me now. I hope that you enjoyed the presentations from our panel. Big thank yous to Renee, Eileen, and Kevin for sharing their expertise and insight. So we're actually going to, this is a convening, and so it's a little bit different than some of the other sessions that you may have attended thus far in the Just Economy conference, and that we're going to do a breakout session in smaller groups for the next, I'd say, maybe 20 minutes or so of the session, or the time that we have remaining of the session. But before I do that, I want to just see if there are any questions that we may have. Feel free to put them in the chat. If there's, maybe one or two questions that we can take right now, we'd be happy to take them. While we're doing that on the back end, I think Chloe will be putting us right now into groups. Into our breakout groups. And once you get into the groups, you'll have the option of providing your comments and insight via a digital whiteboard, or orally if you prefer, or both. Our speakers will be in the breakout groups for the discussion, and then we'll come back to the main room and close out the convening for the last few minutes or so. One last call for any questions. I'm not seeing any, which is totally fine. Again, big thanks to our speakers. I think Chloe is going to move us into our groups right now, and then we'll see you back in the main room soon. And I hope everyone will have a really great discussion. Thanks a lot, all. Hi, everyone. Thanks for joining us back in the session. I was like talking to myself for a long time, and then we all got back into the room, which is great. So anyway, I hope the discussions that you had were fruitful. I'm sorry that we don't have time for report backs, but we really wanted to make sure that folks had an opportunity to talk together. However, I do want to say to folks, and you'll see an invitation coming in your box in a couple of weeks, but we want to continue the discussion. I want to invite folks to participate in NCRC's Healthy Communities Community of Practice. In a couple of weeks, I'll send out an invitation to all that participated today to join NCRC's online platform, which will allow us to connect around the intersection of health and wealth and have these types of in-depth conversations around investment and health. The community of practice, I think, is just a great space for networking, or can be a great space for networking, for sharing resources and information and much more. So please be on the lookout for that invitation in the next several weeks or so. And with that, again, thank you to our presenters. Thank you to the audience, especially those of you who stuck around all the way to the end for being part of the Just Economy session and conference. I hope that folks enjoy more of the sessions for the rest of the week, including a quick plug that I want to make for a session that we're having on Friday afternoon, Policy Options in Community Development for Promoting Long-Term Health Equity. This session will be more specifically focused on the more macro policy solutions for health equity, and I would love to have all of you join us for that session. So again, thank you all so much, and I hope you enjoy the rest of the conference.